Yes, yeah, we'll just have a dialogue. The questions that were sent previously, hope you got a chance to go over those. So we'll just keep it kind of natural and everything, but are you ready to go ahead and get started?
Yeah, sounds good.
Awesome. All right. Good morning. Hello and welcome everyone to Ask Your Doctor. This is an informative health session that is sponsored by My My American Doctor is a group of highly trained and experienced doctors that represent all specialties and provide second opinions throughout the country. We are not here to give individual health advice or treatment plans, but to just give a general idea of certain conditions. If you have questions or need any further clarification, you can go ahead and get in touch with us. I do recommend the live audience to ask any questions. We will go ahead and answer those live here as well. Or you can go ahead and visit our website at myamericandoctor.com or go ahead and give us a call at 919-914-941-494 to book a second opinion consultation with one of our specialists. Today, we are joined by Dr. Krishna Pothineni, a highly respected cardiac electrophysiologist at Kansas City Heart Rhythm Institute, where he was honored as both Fellow of the Year and Faculty of the Year. With advanced training from institutions like the University of Pennsylvania and years of experience treating complex heart rhythm issues, he has helped thousands of patients manage conditions like atrial fibrillation, ventricular tachycardia, and other arrhythmias. Doctor is also a published researcher and award-winning educator known for turning cutting-edge science into practical care. In this interview, we'll explore heart rhythm problems in simple terms, what causes them, how they're treated, and what patients around the world should know. Thank you so much, doctor, for being here today. How are you doing?
Hi, Rihanna. Thanks for having me. Good to see you.
Of course, yeah. Where are you joining us from?
I live in Kansas City, Missouri, so I'm from home now.
Okay, awesome. Yeah, well, we are very excited for today's conversation. We appreciate your passion in this field, and we just hope to learn a lot from you today. So we'll go ahead and get started. Kind of just an introduction here. What exactly is cardiac electrophysiology, and how does that differ from general cardiology?
Yeah, so cardiac electrophysiology is a subspecialty of cardiology where the focus is primarily on treating abnormal heart rhythms. Cardiology encompasses the whole care of the heart, and one portion of that is focusing on the electrical system of the heart, looking at normal signals versus abnormal signals. And when people have abnormal electrical signaling in their heart, they can develop abnormal heart rhythms, which can be sometimes very dangerous. So
Yeah.
electrophysiology is a field where we focus primarily on the electrical system of the heart.
Yeah. And what kind of fueled your passion then for this specialization in cardiac arrhythmias?
So the way we approach cardiac arrhythmias has a lot of physiological basis behind it. So the science behind it is very true in terms of the electrical signaling pathways, how they work, how they can get perturbed, and how we can intervene procedurally to try to interrupt these circuits. So and the reward for the field is highly satisfying in terms of fixing somebody's heart rhythm problems and creating a big impact in their lives. So that's
Yeah.
what kind of fueled me towards cardiac electrophysiology.
Yeah. And how common are arrhythmias then?
So arrhythmias are highly common cardiac disorders, and often they are very under-recognized and undertreated because the symptoms of arrhythmias can be very, very varied. In some people that we see, the most common symptom of an arrhythmia, such as atrial fibrillation, is just being tired and fatigued. And often symptoms that are non-specific like that are often mistaken just to be age-related decline in somebody's function rather than
Yeah.
specific to arrhythmias. So there are other people with arrhythmias who have very, very common symptoms like palpitations. They feel like their heart is skipping a beat, their heart is racing or fluttering in their chest. And those are much more easier to recognize as arrhythmias. But because of the non-specific nature of the symptoms, often arrhythmias go undiagnosed and their overall prevalence is often underestimated.
Yeah. So what are some like early warning signs then that our audience could maybe kind of look out for?
So, for people who have arrhythmias that are very classical, that present with rapid heart rates, heart racing, fluttering in their chest, or skipped heartbeats, It is important not to ignore them and seek consultation to figure out what's happening. Occasionally, people can have an individual skipped heartbeat here and there, but if it's a more persistent and recurring problem, ignoring it is not the answer, and it should seek care as soon as possible. Other people who have other more indolent arrhythmias like atrial fibrillation, you have to keep an eye on how your general health is doing. And if you see that over time you're declining rather rapidly, then that needs more surveillance to look for possible arrhythmias contributing to those symptoms.
Yeah, yeah. And so when a patient is kind of like diagnosed with these arrhythmias, what are the next steps? Are there like medication? What are the technologies and things that go into this?
So, cardiac arrhythmia is a broad term, and there are several different kinds of rhythm problems that patients can have. Some rhythm problems come from the top chambers of the heart, called the atria, and some rhythm problems come from the bottom chambers, called the ventricles.
Mhm.
So, once people get diagnosed with a heart rhythm problem, the management and future steps are very dependent on what kind of rhythm we are dealing with. Patients who
Mhm.
have atrial rhythm problems have one kind of treatment options, whereas those with ventricular rhythm problems have a different kind. Broadly speaking, treatments for arrhythmias can either be number one, just reassurance and watching, just keeping an eye on how the burden of arrhythmia is translating over time. There are medical options where we can use medications to slow the heart rate or medications to break abnormal rhythms. And in this current day and age, the most common treatment option for arrhythmias is something called catheter-based ablation, where we can actually map somebody's electrical wiring system in their heart, identify the abnormal circuits and foci where abnormal signals are coming from, and we can deliver some energy to kill those abnormal spots and fix those rhythm problems. That is
Yeah.
one side of electrophysiology care we do, where we deal with fast abnormal rhythms. The second side of electrophysiology deals with slow rhythms. Normally all of us have a heartbeat that needs to go at 60 to 80 beats per minute on an average. And there are people who have a slowing of their heart rate significantly, or they have slowing of electrical pathways in different parts of their heart, which makes their ECG looks very abnormal and can contribute to a condition called heart failure. In this subsection of patients with slower heart rates or slowing of electrical signaling in their heart, we have device-based therapy where we can implant pacemakers, defibrillators, and more advanced devices to try to support their heart rhythm. So once you get diagnosed with an arrhythmia, what we do next and what to expect is very, very dependent on the kind of rhythm problem we are treating with.
Yeah, yeah. That's amazing, kind of the technologies that are available today. It's just so intriguing to listen to. So we kind of know over time, our body breaks down, our heart muscles kind of get weaker. So are people who are older adults, are they more prone to heart rhythm problems? And do their symptoms kind of differ at times?
Yeah, that's a great question. So, age is a very, very important risk factor for cardiac arrhythmias. I often tell my patients, just like how our hair gets gray with age, the electrical pathways in our heart are at a higher risk of getting short-circuited or getting
Yeah.
slower, which can lead to an increased risk of arrhythmias in the elderly. So, the most common arrhythmia that we see in the US, for example, is atrial fibrillation, which is an irregular rhythm that comes from one of the top chambers of the heart. And if you look at the epidemiology of it, patients who are 70 and above almost have a 1 in 10 chance of developing atrial fibrillation in their life. So you can
Mm.
imagine with the population being so high, if 1 in 10 or 1 in 15 is at the risk of developing an arrhythmia, it's just a huge epidemic of atrial fibrillation. So,
Yeah.
as you mentioned, age is a very important risk factor. And patients often at who are 70 and above, for example, if they notice a decline in their capacity to do something, they often attribute that to their age. And they would think, oh, I'm 70 years old, that's why I'm slowing down. I'm not able to
Yeah.
do this activity which I did 5 years ago. But that may not be true. It may be because of the arrhythmia like atrial fibrillation limiting their activity.
Yeah, yeah. So as patients kind of get older, is treatment a little bit more riskier than in those elderly patients?
Fortunately, no. Even if patients are older, 70, 80 years old, the treatment approaches we have for most arrhythmias now have a similar risk. It's not terribly high risk. These procedures are not terribly high risk. And compared to operating on somebody who is 50 years old versus 70 years old, doesn't really change the risk equation in a major way.
Yeah, that's awesome to hear. So like do you use like pacemakers and kind of different treatment options, devices like that? Is that something that you typically provide to your patients then?
Yes, so depending on what the patient is having, if we are
Mhm.
dealing with slower heart rhythms, then the discussion is more geared towards device-based therapy, such as pacemakers and defibrillators. A big chunk of people who have heart rhythm problems also have concomitant heart failure. So when we are treating heart failure, a lot of risk stratification and a lot of device therapies to prevent sudden death come into play. And that's where we implant devices called defibrillators. When we're dealing with people with fast heart rhythms, people are often coming to our ER, walking in with a heart rate of 200, 220 beats per minute. Then we'll have to figure
Yeah.
out where this abnormal rhythm is coming from and potentially fix it with something called ablation.
Yeah, yeah. And so what advice kind of helps these kind of older elderly patients to kind of maintain a normal heart rhythm then?
Yeah, so a regular heart healthy lifestyle is good for overall heart health, whether it comes to preventing the risk of a heart attack, preventing risk of progressive plaque formation in their blood vessels, or and the same lifestyle modification and heart healthy lifestyle also contributes to lower risk of arrhythmias. Unfortunately, most people who have arrhythmias, they have it because of degenerative changes in the electrical wiring of their heart. So this is just an age-related process that happens, and it's not something they are doing for to trigger these episodes to happen.
Mhm.
So there is no specific lifestyle change that can reduce the risk of your arrhythmias, but an overall heart healthy lifestyle has been shown to be better.
Yeah, awesome. Yeah. Well, you keep kind of using this word defibrillation, atrial defibrillation. Could you kind of expand on that? And what exactly is that?
So you mean so a defibrillator is a device that is often implanted in people who have a low heart function. When
Mhm,
somebody has heart failure, we can assess what their heart function is. And
mhm,
what we know for sure is that people who have a low heart function are at a higher risk of developing some dangerous heart rhythm problems. Some of them are called ventricular tachycardia, ventricular fibrillation. These are dangerous rhythm problems that often lead to sudden death. We often
mhm.
hear about people passing away in their sleep, and usually they happen because of some dangerous rhythm problems that happen. Defibrillators are devices that can monitor somebody's heart rhythm all the time. And if they go into a really dangerous rhythm problem, they can stop the rhythm either by a shock or by pacing and basically save people's lives. And they save a
Yeah.
lot of lives in people who have heart failure. That's the concept of an implantable defibrillator.
Yeah, yeah. And so, what is AFib then, and why is it so dangerous when gone kind of like untreated in certain patients?
Yeah, that's a very important question because atrial fibrillation, in short form, we call it AFib, is the most common arrhythmia worldwide currently as we speak in 2025. And as we discussed earlier, with age, the risk of AFib goes up. And if you're 70 and above, there is a 1 in 15 chance you're going to develop AFib in the future.
Yeah.
The biggest problem with AFib is twofold. One, it is a very important risk factor for stroke. So, when people have atrial fibrillation, normally when somebody is in normal rhythm, which we call sinus rhythm, the top chamber of the heart, the atrium, is squeezing nicely with every single heartbeat. So, there's good blood flow going on. When people develop atrial fibrillation, the top chamber, instead of squeezing with every heartbeat, is just moving like this, it's quivering. So the blood here tends to stagnate. When blood
Yeah.
stagnates, it tends to clot, and the clot can break off from the heart and can get thrown to the brain and can cause a
Or
stroke. So patients often present with stroke as their primary symptom. We see people with paralysis, not being able to speak, and that's all because of strokes that happen in the brain.
Yeah.
AFib contributes to about 25% of strokes in the world. Almost
Wow.
25% of strokes that happen are because of AFib. And because the symptoms of AFib are often very, very underdiagnosed, the
Yeah.
first manifestation clinically could be a stroke. So that is one very important factor that we need to remember about AFib. Detecting AFib can be an opportunity to prevent a future major stroke from happening. And the
Yeah.
second issue that happens with AFib that's not diagnosed and treated properly is AFib is a very important risk factor for heart failure. So if somebody has AFib that's undiagnosed and untreated, they can progress to the point where their heart function actually declines and they develop clinical heart failure. So
Wow.
that for those two reasons, detecting AFib and treating AFib optimally are very important.
Yeah. So when you have a patient that comes in and you realize they do have AFib, then like, how do you choose between the medication, the shock therapy, the procedures? What does that kind of process look like then for the patient?
Sure. So AFib management is very individualized depending on your risk of a stroke, depending on how much AFib you're having, which we call AFib burden, and how symptomatic you are. If you're having a lot of symptoms, every time you have an episode of AFib, you feel a lot of symptoms, then we have two options. One, we can try anti-arrhythmic medications. These are special medications designed to control heart rhythm problems. And those medications have a success rate of about 70 to 75% in keeping
Oh,
AFib
wow.
under decent control.
Yeah.
The second option, which is the more preferred option nowadays, is to undergo something called catheter ablation. Ablation is a procedure where we can actually map the electrical system of the heart, identify triggers for your AFib, and we can basically cauterize or burn all those abnormal spots so they don't fire
Wow.
too much and cause more and more AFib. That
Yeah.
procedure is done very commonly and it has a success rate of close to 90% at keeping AFib under better
Wow.
control. Whatever modality we choose, the bigger impact is on the timing of intervention. Whether we choose medications or whether we choose ablation, the earlier we hit it, the better it is in the long term. The longer
Yeah.
somebody has AFib and now we are trying to catch up and fix the rhythm, the overall success goes down, whatever modality we take.
Yeah, yeah. I think those success rates are incredible to kind of hear. So when that happens, then it's not technically a cure. So could kind of those things come back then? Like what lifestyle changes help prevent that com like from coming back then after that success rate is so high?
Yeah, that's a great question. So what I often tell my patients, right, if I quote you a success rate of 70% with an intervention, if you follow a healthy lifestyle and prevent potential triggers from AFib from happening, such as
Yeah.
alcohol, controlling your diabetes, controlling your hypertension, things like that, then the success goes up by 10 to 15%. One
Wow.
big lifestyle change that has been shown in randomized trials to help is weight loss. Every
Yeah.
10% drop in your body weight improves the success of AFib ablation by about 3%. So if
Wow.
you so most of my patients that we do an ablation on, the counseling we provide is for these lifestyle changes, control diabetes, hypertension, lose weight, and the success of ablation goes up even higher.
That's awesome to kind of hear that success. And like patients always love to hear that their symptoms and their issues can be kind of helped and solved with these kind of lifestyle changes. So that's really inspiring to hear that actually really makes a difference. We actually did get a live question here. What is Watchman device? And if any patient gets it, are they not at risk of a stroke? Can they be off of blood thinners?
Yeah, very important aspect of AFib management. As we discussed earlier, AFib increases the risk of having a stroke because of those blood clots forming in the heart. So, one of the most common ways we try to prevent a stroke in people with AFib is to put them on blood thinners. There are several
Yeah.
blood thinners on the market, which basically thin your blood out, so the risk of a clot formation goes down.
Yeah.
Any blood thinner, because it thins your blood so much, increases the risk of bleeding. So there are people whom we put patients on blood thinners, and they start having bleeding in their stomach, in their intestines, sometimes in their brain, sometimes in their urine, and that prevents us from using blood thinners long term in these patients. So
Yeah.
Watchman is a device that has been developed as an alternative to using a blood thinner. So when we look at the left atrium, the left upper chamber of the heart, all of us have a little sac-like structure in the left atrium called the appendage.
Hmm.
When people have atrial fibrillation, that is the most common site where blood clots form.
Hmm.
So, and that's what we are trying to prevent with a blood thinner. But let's say I have a patient in whom I cannot use a blood thinner. They had a bleed in their brain in the past, or they have an active ulcer in their stomach that tends to bleed if I put them on a blood thinner. In those patients, what we can do is there's a little plug like device called a Watchman that we can implant inside the left atrium and seal this sac off. So even if a clot forms here, it can't go anywhere, it can't go to the
Yeah.
brain. So in
Yeah.
those patients, after we put the Watchman device, we can stop their blood thinners after a few weeks.
Yeah.
It is not better than a blood thinner. It is just an alternative to a blood thinner in people who cannot take blood thinners long term. So to answer the question, in people who get a Watchman device, yes, we do stop their blood thinners after a few weeks.
Yeah.
And that's
Yeah.
an alternative in selected patients, not for everybody.
Of course, yeah. Thank you for answering that question for us, doctor, and thank you to our audience for asking these live questions. We are here to answer whatever you have, so feel free to ask at any time. Let's kind of go into ventricular tachycardia, also known as VT, and ventricular fibrillation, VF. Why are VT and VF so serious? Could you answer that for us today, doctor?
Sure. So ventricular arrhythmias are much more malignant than atrial arrhythmias. And even
Okay.
within ventricular arrhythmias, you can have a whole spectrum of arrhythmias. People sometimes come with single extra beats in their ventricle called PVCs, premature ventricular complexes. Those
Yeah.
patients are much, they do feel symptomatic, but they're not collapsing. Patients with more serious rhythm problems like ventricular tachycardia, which is a very fast circuit going in the bottom chambers of the heart, or ventricular fibrillation, these are the high risk patients. These patients often present either with a cardiac arrest or syncope, where they completely pass out, or
Yeah.
extreme dizziness. And
Yeah.
because when people have ventricular tachycardia or fibrillation, the bottom chambers of their heart are going so fast that they are not able to sustain blood flow going through their body. And they present
Yeah.
in various forms of severity. And most people who have what we call sudden cardiac death, where people suddenly collapse and die, it's because of these rhythm problems, either ventricular
Yeah.
tachycardia or ventricular fibrillation.
Yeah.
So, identifying people who are at high risk for these rhythm problems and trying to prevent them from dying suddenly becomes very, very important. So, we
Yeah.
often put defibrillators, like we discussed earlier, to try to prevent these people from dying suddenly. And
Yeah.
once we know that they're having a lot of these arrhythmias, we often bring them to the lab to try to fix them with again
Yeah.
medications or with ablation.
Yeah. Yeah. So does a lot of testing go into this then? Or like with patients that have these, are they asymptomatic? Do they have symptoms?
So, but for people who have those single heartbeats called PVCs, they often
Hmm.
feel them. They feel like they're fatigued. They have these skipping heartbeats. They feel like they have strong heartbeats occasionally that makes them feel uncomfortable. Patients
Yeah.
who have VFib often present with cardiac arrest or completely passing out. And patients
Yeah.
who have ventricular tachycardia can either present with symptoms or they can present with much more dangerous situations.
Yeah.
When people come with ventricular arrhythmias, there is a basic testing that we do to figure out what's happening. One is we get an echocardiogram to look at their heart function, look at how their valves are behaving to understand the structural processes of their heart. We often do some testing to look for blood flow of their heart. So we do either stress testing or sometimes we do coronary angiography to look at how the blood flow to their heart is looking. Cardiac MRI is an emerging modality where we can look at the heart muscle in much more detail and identify where potentially there could be scar within the heart muscle. And usually, and then an EKG is always done in these patients to document the arrhythmia. And sometimes we need more long-term rhythm monitoring to try to capture more rhythm issues. So patients can
Yeah.
often get patches that they need to wear called holters or event monitors to try to capture these rhythm problems. So that would be
Yeah.
a basic battery of testing when somebody has ventricular arrhythmias, and the treatment depends on what we find.
Yeah, yeah. And so these patients that have these arrhythmias, when exactly is a defibrillator then kind of recommended?
If somebody comes in with a cardiac arrest to the hospital, and we know the cardiac arrest happened because of a ventricular arrhythmia, they often leave the hospital with a defibrillator because
Okay.
nobody can predict when the next episode is going to happen.
Yeah.
For other people, if it's a reversible cause for an arrhythmia, like they had a heart attack and that's why they had the rhythm problem, then we don't put a defibrillator in because we know that there's a cause that we can fix and hopefully this won't happen again. So it really
Yeah.
depends on how severely the patient's initial presentation is.
Yeah. Yeah. And so are there ways then for these high risk patients to possibly prevent VT or VF from happening then?
It is, that's very difficult to predict. You know, sudden
Yeah.
cardiac death is often very difficult to predict when it's going to happen. So, in
Yeah.
people who, let's say, somebody had a heart attack in the past, and we know that they have a significant amount of scar in their heart muscle, then we know these people are at a higher risk of bad rhythm problems happening. So, we put
Yeah.
prophylactic defibrillators to protect them.
Okay.
But in somebody who has no scar in their heart muscle, there are several other rhythm problems that can precipitate ventricular fibrillation, but it's very, very difficult to predict who is going to have one.
Yeah, yeah. And so kind of when we talk about kind of slower heartbeats, what causes this exactly then? And when exactly would a pacemaker then be needed? When would you kind of recommend that for your patient?
So the most common reason for somebody having a slow heart rate is aging. Just like the hair gets gray, the electrical system gets slow with time, and you know it's wear and tear of the electrical system. And usually, when patients present with symptoms of a slow heart rate, which could be dizziness, feeling like they're about to pass out, or feeling like they're very fatigued, they can't get their heart rate more than 60 or 70 even with activity, those are
Yeah,
all signs that the electrical system is slow and limiting what the patient can do. And that's when the
yeah,
conversation about a pacemaker starts. There are
okay.
other people who actually present with conditions like complete heart block, where the electrical wiring of the heart completely gave up and their heart rate is going really, really slow. And those
Yeah.
patients will require more emergency pacemakers.
Hmm. And are pacemakers then, are they like implanted into a patient or are they kind of just a device that they carry around with them? What does that kind of look like?
So pacemakers are implanted devices.
Okay.
Usually pacemakers come with two components. There is a battery for the pacemaker and there are wires that go and connect to the heart muscle. So usually the wires are put through a vein near the shoulder and and once we place them in the appropriate positions in the heart, we connect them to the battery and the battery is placed under the skin. Most people
Okay.
have it on the left side, just under the collarbone, under the skin. And
Okay.
once you get a pacemaker, the battery on the pacemaker lasts about 12 to 15 years. And when it's
Okay.
time to replace the battery, the physician usually just opens up that incision, changes the battery, and closes back again.
Okay.
Pacemakers have been around since 1960s, you know, wonderful devices that save a lot of lives.
Yeah, yeah, they seem kind of simple then to use and to rechange the batteries and such. So that's awesome that that's available to the patient and has been around for so long. Yeah.
Definitely.
So yeah, our audience would like to know about kind of sick sinus syndrome. Could we just start with you kind of explaining to us what that is exactly?
Yeah, sick sinus syndrome is just another medical term for a slow heartbeat. So all
Okay.
of us have a natural pacemaker in our heart called the sinus node. which is programmed to go somewhere between 50 to 80 or 90 beats per minute for most people.
Hmm.
Over time, as people get older, this rate on the sinus node tends to get slower and slower. So some people may have their sinus node only going at 40 beats per minute, and which makes their natural heart rate 40 beats per minute. So that
Hmm.
condition where the sinus node gets slower and slower is called sick sinus syndrome. And the most
Okay.
common treatment for that is to put a pacemaker so we can pace the heart faster than that at whatever rate we think is appropriate.
Yeah. So sick sinus syndrome and then just like slower heartbeats, they are pretty much the same thing then? How is
Right.
that?
If the
Okay.
low heart rate is coming from the sinus node being slow, the sinus
Yeah.
node is the natural pacemaker of the heart. That's called sick sinus syndrome. In some people, the sinus node is fine, but the connection between the atrium and the ventricle is one more area called the AV node. That's where the problem is. In those people, they don't have sick sinus syndrome, but their overall heart rate is very slow because at the second level in their heart, they have an electrical block. So
Okay.
even that can cause a slow heart rate. So there are several, depending on which level of electrical circuit you have a problem, there are several reasons why somebody can have a slow heart rate. If it's
Yeah.
happening in the in the top step in the sinus node, then it's called sick sinus syndrome. If it's happening in the next step, it's called AV block.
Okay. So then specifically with the sick sinus syndrome, then that's when you would recommend a pacemaker to your patient then?
For wherever the level of the block is, the treatment for a slow heart rate is a pacemaker. Where we
Okay.
put the leads in the heart, what kind of programming we do for the pacemaker depends on where the level of the block is.
Yeah. Yeah. And so a pacemaker would then be a surgical procedure, correct?
It's a surgical procedure, but it's a minor surgery. It's not open heart
Okay.
surgery. It's a
Yeah.
small incision about 3 centimeters in length that happens in the left shoulder area. And
Yeah.
most people can go home after the procedure the same evening or the next day.
Yeah, that's awesome. So are there any then maybe non-surgical treatments available to these patients, or is it just pacemaker? That's all that's kind of out there.
Unfortunately, for slow heart rhythms, the only treatment we have is device-based therapy, putting in
Okay.
pacemakers. There is no medication that can really solve the problem or increase somebody's heart rate. For
Yeah.
fast heart rhythm problems, we always have a choice between either trying medications or doing a procedure called ablation, like we discussed.
Okay. Yeah. Yeah. And to kind of end our conversation here, I would love to kind of go back into the treatment tools, the devices, the procedures that kind of are available to these patients who are dealing with these. And so just kind of again to talk about ablation here, is it safe and how long is that recovery time?
Yeah, ablation has really the technology for ablation has really evolved over the last 10 to 15 years in a tremendous way. Technology advances have really helped us identify areas in the heart that are very critical for various arrhythmias that we can easily fix now. The procedure itself is again minimally invasive. The way I'll just go give you an overview of how an ablation is done. When patients come to the lab for an ablation, usually we just go through the vein in their leg. You know, there's a vein called the femoral vein in the leg. We put a
Okay.
small IV there. From there, we can put catheters that go into the heart. We can create a map, do everything that we need to do. Most of these ablation procedures last about 2 hours long, and after the
Okay.
procedure, patients are on bed rest for about 4 to 5 hours. After that, they're free to get up and walk around. Mostly, it's one overnight stay in the hospital for observation, and the next morning, patients go home. The safety
Okay.
of the procedure has been tried and tested. The overall risk of a complication happening with an ablation procedure in current day and age is about zero point 0.5 to 1%. So
Okay.
99 out of 100 times or even more, these procedures are completely uneventful, and patients walk out with good success rates.
That's awesome. That's awesome to hear. So are there, I love ending kind of our conversation with new technologies or advancements or anything, maybe devices that are coming out. Are there anything that you are excited for coming up
Yeah,
as
there
far as like home monitors and such for patients?
Right. So electrophysiology has always been a field of great technological advancements.
Yeah,
For example, in ablations, now we have a newer technology called pulse field ablation, which delivers a different kind of electrical energy to kill heart cells. There's a lot of innovation going on in that field when it comes to
yeah,
ablations. When it comes to devices, now the movement is going towards what we call leadless pacing, which means
yeah,
that earlier when we spoke about a pacemaker, I told you there are wires that go in the heart that stay there. And as you can
yeah,
imagine, when you leave wires in the heart, there could be problems down the line because of those
yeah,
foreign bodies in the heart. Now we have devices called leadless devices where the size of the pacemaker is about this much. It's about the size of a small bullet that we can just
wow,
implant in the heart and come out, and nobody knows that the patient had a pacemaker.
yeah,
And when you talk about home monitoring, we are moving more from medical grade monitoring to consumer level monitoring now. With Apple Watches, Fitbits, Garmin watches, everybody has access to their EKG and their heart rate data.
yeah,
So I think that's where the future is going, where we don't have to recommend patients to wear monitors. Patients
yeah.
already have wearable monitors that will detect something, and they will come see the doctor for further advice.
Yeah, and I think that's awesome too, because it's more of like a fashion statement sometimes with these Fitbits or these watches, rather than someone kind of having to carry around a big device and they may not be comfortable going out in public with that. So I think that's awesome that these technologies and these advancements are here for our patients. Before we end our conversation here, we did get another live question from our audience. He said, I go to Orange Theory and they talk about heart rate variability and high intensity training exercise. What is the impact on cardiac health in overall?
Yeah, so gyms like Orange Theory and other HIT workouts, they look at the heart rate zone where they think one zone leads to more fat burning. There is actually good data to support that if you do short intensity, high intensity, short interval exercises, there is actually good data to show good cardiovascular benefit. And even low intensity, long duration has similar impacts. So to talk about heart rate variability, the variability that we get with high intensity exercise has really no significant impact on overall heart health. Heart rate variability when somebody is at rest is a sign of how the autonomic nervous system impacts their heart, but the zones that you get to when you exercise doesn't really impact your heart health in a bad way over long term. Those zones are more designed for which fuel your body uses for sustenance at that level of activity.
Okay, yeah, thanks for clarifying that us for us here. One more thing I kind of want to end on then, is there something then that you could recommend maybe to a younger audience then to keep their heart healthy, to just maintain a healthy lifestyle? Is there any words of encouragement or anything you would encourage our kind of younger audience to pay attention to?
Yeah, definitely. I mean, heart disease, whether we talk about blockages or arrhythmias, is cumulative over your lifetime. So the earlier we get on it and try to prevent these hits from happening to our heart is better over long term. In terms of lifestyle modification, my biggest pet peeve is two things. Cigarette smoking and alcohol are highly bad for the heart. So if there's anything that if there's one advice I can give is don't smoke cigarettes, try to lose weight, and those two would have a great impact on overall heart health over your lifetime.
Yeah, awesome. Well, thank you so much for being here with us today, Doctor. We just appreciate everything you shared with us, your expertise. We can just tell you're very passionate about this field and your patients. So we just appreciate everything that you have enlightened us with today. We look forward to seeing more of your work and your contributions in the future. But in the meantime, just have a wonderful weekend. We really appreciate your time, Doctor.
Thank you very much. It was very nice to be here.
Thank you. Bye-bye.
Bye.